Alex, I had to rejoin by my phone.
Okay.
My internet kicked me totally out of Zoom, so sorry about that. I see Dr. Greiner is now on.
Yes.
Oh, hello.
Hello. Welcome. Well, it's 4:04. I think we may have some other people join as we continue. But I did want to just welcome everybody today to our Foundations of Global Health and our presentation with Dr. Greiner. Some of you have already attended a few of these Foundations of Global Health presentations. It's a series that will go throughout the year, where hopefully from year to year, the goal is to develop a foundation of global health understanding, philosophy, attitudes with our students, residents, and faculty who might be new to this field. So we've asked some of our experts like Dr. Greiner to join us and tell us about their journey in global health, lessons learned, you know, the attitudes and the tools and skills that are necessary to be successful in this field.
Mm-hmm.
So we have some upcoming events, and you guys can see these. We look forward to having restarting after the holidays with in January, a late January event with Dr. Barr. And then we have another one in February with Dr. Halsey, Dr. Mish Lawson, and then again in March, we'll have Dr. Malfatti. At this point, I'll quickly introduce Dr. Greiner.
Don't read
a lot
all
of you
that.
don't leave on. Okay, I won't read.
Don't read all that.
Okay, so a lot of you probably already know Dr. Greiner, and actually, Dr. Greiner, I think you're probably best at introducing yourself and what you're actually involved with. But as you guys probably know, Dr. Greiner has extensive experience conducting clinical research activities, both in the tropics and in urban and rural communities. He has directed several large clinical studies, specifically looking at interventions for improving cancer screenings. Dr. Greiner has served key leadership roles in multiple NIH-funded studies in rural settings, including his recently completed role as a PI on the Cancer Networks Program Center grant from the National Cancer Institute. And I think that maybe ended in 2017. I know recently you've been very involved with COVID-19, and a lot of your work is around that currently. So I'll just go ahead without any further ado, Dr. Greiner, I'll hand it over to you.
Great. Thank you, Kimberly. And we'll just try to keep this informal. I didn't do any slides or anything like that. So please interrupt as we go, and I may even throw questions out as we get into this too. I know a few of the folks on the Zoom today, but not a lot of you. So please chime in and ask questions as we go. I think what I'll try to do is tell you a little bit about my background and how I got into doing the various things I'm doing, and even though in a lot of ways I wouldn't say I'm a global health expert or researcher. I think probably my thing can apply to the global health arena, because I think what I've really embarked on is trying to work on health equity and become kind of a health equity researcher in my career. So I think if you have interest in those kind of things, global health would certainly fit within that. But I think there's all sorts of opportunities always to do interesting health work with populations or groups of individuals that need to have improved health. And that's true whether we're looking right out the back door here in Wyandotte County, or whether we're looking across the globe to the far reaches of any continent. I'll get into COVID a little bit, because I think for me it's been in a lot of ways a real challenge, but a real energizing time, because it's highlighted a lot of health inequities that exist, and kind of in some ways made me realize that there is hope to do, even with limited resources, to do things that can make a difference for health inequality. So I'll touch on that a little as we go, but again, feel free to jump in and ask questions as we go, or put comments in the chat, or suggest things that you think others might be interested in the chat as we go, and we'll do that. So a little bit about my background. So I'm actually from Kansas originally. I was born in Emporia, Kansas, and lived there till I was 7 or 8, and then moved to Topeka, Kansas, and went to high school at Topeka High, which is the original high school in Topeka, and is sort of in central Topeka. And somehow I got in my head I needed to get out of Kansas and go to college. So I went to Brown University in Rhode Island. I don't know where that idea got in my head, but I went there, and I ended up majoring in anthropology in college. And so that probably explains why I'm here talking to you now about global health. I think that stuff has influenced me throughout my whole career. In fact, probably my growing up in Topeka, although it to many folks across the United States, they probably wouldn't think a place like Topeka was very diverse. It's not a whole lot different in central downtown Topeka than it is here in Wyandotte County, where approximately a quarter of the population is African American, and you've got your third and fourth generation Latinx communities that moved here to work on the Santa Fe Railroad generations ago. I grew up with the same kind of people that live in Wyandotte County, and I think that's probably how I ended up working here. I grew up playing sports with all these kind of people, and in some ways, when I went to the East Coast, and when I was in Rhode Island, I was sort of shocked that even though there was a lot of diversity, it seemed to me that people sort of self-segregated in a different way than I was used to in the Kansas environment. And maybe that's just because I was young and naive, growing up in a place like Topeka. But in some ways, I was ready to get back here after going to college somewhere else. So I came back, and I really didn't know what I wanted to do. I was kind of late deciding I wanted to do medicine and healthcare. I really didn't have a whole lot of interest in it growing up. And then I took in addition to my anthropology stuff, I took some science classes in college, and really liked these neuroscience classes that I took. So then I took some more science classes, and the next thing you know, I'm like, well, I guess I could go to med school because I've taken all these science classes. And so I ended up here going to med school. I don't think I really knew much about what it was all about. I didn't have any family members who were in medicine or healthcare. I don't even think I had a good sense of what a residency is, or how long it takes to get through and be fully trained and doing medicine. I think I was interested in in some of the academic stuff early on. I did as an undergrad, I got exposed to scientific literature and research studies. And in some ways, I think that got me interested in how we develop the science that establishes medicine and healthcare, or that drives it forward. But pretty soon in med school, I think I was frustrated and irritated that it was so focused on science, and so much in that time. And I think it's changed some, but 30 years ago, it was kind of this idea that if you don't know all this science and you don't have all these scientific facts in your head completely memorized, then you're not going to take very good care of people, and people are going to have bad outcomes. And that was frustrating to hear. But at the same time, there was kind of this revolution going on, where there was a lot of feeling that healthcare had to change, and that primary care was going to be a big part of a changing healthcare landscape. When Bill Clinton was elected president, there was a bunch of work on healthcare reform that totally flopped and failed. but it stimulated a lot of the early managed care activity in healthcare and health policy. And there for about 10 years in the 90s, there was a lot of interest in this idea that primary care could become a bigger focus of healthcare in the United States, like it is in a lot of other countries around the world. So as some of you know from your global health work, right, there's a lot of other industrialized countries as well as less industrialized countries that focus a lot more on primary care service delivery and a primary care workforce more than they do on a specialist and subspecialist workforce. And so that was something I thought would happen, as many of us did. Well, it didn't really pan out, right? It sort of flopped by the end of the 90s. But I was through my frustration, I started finding other things to do. And so one of the things I started doing is hanging out in the History of Medicine library here on the KU Med Center campus. It turns out that in the field, in the history of medicine field, as it evolved away from this idea that we should celebrate these white men discoverers of new therapeutics, right? And moved into the idea of understanding how cultural and social forces influence the development of professions and the changes that happen with a field like healthcare and medicine. There was a lot of anthropology infused into that, and some of the professors, I don't know if folks know Dr. Chris Krenner, the current chair of the Department of History of Medicine, but some of the professors before Dr. Krenner had also trained at Harvard, and I don't know if folks know this, but at Harvard Medical School, they have a history of medicine department that's basically merged with their medical anthropology department. And a guy named Arthur Kleinman was there for many years. Some of you may have read stuff by this guy, Arthur Kleinman, who's a psychiatrist and anthropologist. And so we actually have a long-standing influence here by this merged idea of understanding how culture influences things, which of course is a big deal for global health, but it's also a big deal if you want to understand healthcare and medicine, because in healthcare and medicine, we sort of always assume that there are these scientific discoveries that happen and we put them into play with some sort of new therapeutic or preventive strategy, and things get better. And then we discover some more stuff and things get even better. And then we discover some more stuff and things get even better. So it's this sort of mythology that things are constantly moving to an always improved outcome. But because of cultural and social forces, there are actually a lot of other things going on that are driving what happens and what becomes the standard of care. And so you could very easily argue that our whole system in the United States is quite screwed up, because it's really evolved in many ways to generate wealth and income for a certain sector of the population and leave a whole bunch of other people out. And that's where the whole idea of working on inequalities comes from. So I hung around in the History of Medicine library and thought about this stuff while I was also doing medical school. And some of the same folks who worked there were like, you should do stuff in the community with underserved populations. I'm like, yeah, you're right. That sounds great. So I started doing some things with local safety net clinics and with local nonprofits. And that's when I kind of learned that to me, Wyandotte County felt kind of like how Topeka felt when I was growing up. Very diverse, lots of opportunity to do things to help people, a sort of very welcoming environment if you came in with an open mind. And a lot of what I learned in anthropology was some of this relativist thinking. Now I don't know if anybody's ever read anything that got into sort of relativist thinking, right? But this same philosophy about how healthcare and medicine is always coming up with something smarter and better, and the outcome that we get is always better and better and better, and it just stacks up on top of each other. That you guys realize, right? You wouldn't be at this talk today if you didn't realize that all of Western society does this same kind of goofball mythology thing of like, we're Western society. We come up with great ideas. It makes the world better. People live longer. We're constantly stacking it on top of each other. And we have this social evolutionary thing going on. Well, it's a myth, right? We wouldn't be interested in global health or in inequities if it wasn't a myth, because there are always people left out. And some would say, right, that some of the stuff we see as advancement is actually just a way to kill the planet, right? Quickly or slowly, whichever way you look at it. But so we neglect that, right? We go through phases in the United States, certainly, where we neglect this critical analysis of how much of a myth social evolution is. I would say clearly, though, COVID is a great example of showing what a myth it is, as are our current politics in this country, right? The things that are going on politically, the amount of polarization of people in many ways, to me, is an acute reflection of the fact that we're not evolving. We're just constantly moving in a different direction. And there are a bunch of social and cultural forces that are behind those movements. Now, some of us have to play this little game, right? If you're a researcher, like some of us are, you're kind of playing this scientific game where you want to learn more about scientific advancements, and you hope that's going to lead to improvements. But you got to keep reminding yourself at the same time that probably, and this is what I'd try to do anyway, probably the place to apply anything new that's discovered that could be helpful is with the sort of most neglected and the most left behind portions of our different populations. Unfortunately, that can be tough, right? When you have a healthcare and medical system that's really become a massive economic engine and is all about, in large part, all about economic forces and sustaining this sort of growth of an enterprise that that doesn't always apply things equally. Now, at the same time, they got this sort of myth, right, of a constant evolution. You also have this myth of healthcare and medicine is sort of like going to help everybody, right? So we do have laws like EMTALA laws that say if you show up in the emergency room, you have to get taken care of. But that doesn't help you much if you have a big cancer on your neck that's not an emergency, and they're going to send you home from the emergency room, and then there's absolutely no way for you to get this cancer cut off your neck unless you have enough money to pay a surgeon and an anesthesiologist and a hospital operating room for their expensive services to do that. So the inequities persist, and I think they exist really, as all of you know, I think they exist all across the globe. Another thing I think I feel like having studied lots of different cultures is that certainly Western culture, in addition to having this sort of manifest destiny, social evolutionary way of seeing things, it's also very very grounded in exploitation, right? That this idea that you always have to have some segment of the population that's being exploited for those that currently hold the power and control. And that's a kind of a constant if you go back and look at the way Western societies developed. There's some of that probably across the globe, right? With other cultures, other societies. We're just not very far away from the idea that exploitation is always okay and is always fine. And cultures and societies are constantly coming up with a new twist on it to rationalize it and call it by another name and frame it in a way that it looks reasonable and rational. And so we have here in our country, right, we have this American dream idea, and this idea that, well, if you just work hard, you'll succeed, and things will be good for you. And there's very little talk about the ways in which that kind of cultural ideal, it can really lead to a lot of exploitation. And there's a whole bunch of other structures right in place that reinforce that exploitation. So with that said, there's a whole bunch of opportunity to do good work with populations or segments or groups of people that do not have the best of outcomes, whether those outcomes are economic or social or health related outcomes. I think what we are seeing, because of the level of inequality and exploitation that's happened in our country over time, we are currently seeing a very tight connection between what's happening with people's economic lives, their social lives. You hear people talk about social determinants of health all the time. And social determinants of health are driving a whole bunch of health outcomes for people in this country right now, because we have become so much more inequitable than we were at one time. So not that we were ever very good, right? This country is a country founded on slavery. I think many of you would agree with me, and this might be controversial to some, but many of you would agree with me that this country's wealth and power is basically comes out of the framework of a slave-based Southern economy that takes land resources co-opted from American Indians and then has a labor force that's enslaved, that generates wealth and power that becomes global wealth and power, and it's never been truly acknowledged. And I can find plenty of people in the next building over who would probably argue with me that this is true, but it's probably very much true. And I think as historians look back on this, they'll agree. But there have been times, I think, when we had less inequality than we have now. And so that some of the structures we have now have led to crazy things like the COVID epidemic and its impact on minority populations and marginalized groups. It's as I'm sure many of you have read about this and seen things that are going on with COVID. But it's just dramatic how much the incidence and the case rates are higher in minority populations, as well as the bad health outcomes. And it's a multifactorial process that's got us there, but the structural inequalities and the way that they're sort of set up to keep themselves going and to keep those in power have not only made it so that people can't avoid getting sick, right? If you work in an environment where you're standing on top of other people all day long in a meatpacking plant or in a factory environment, and you can't call in sick and you don't have any sick leave anyway, so you're probably not going to report your symptoms when you do get sick, and you've got all sorts of payments to make, so you need that income. You're going to see transmission happen at higher rates, and then you're going to see bad health outcomes because of some of the ways that systemic racism and systemic inequities play out, right? I'm sure many of you have heard about how things like the social determinants of health lead to higher allostatic load on people from minority populations. Allostatic load is basically this idea that, for those of you who haven't seen this kind of stuff, that if you're chronically stressed, your health outcomes are going to be worse across the board, and even something like an infectious disease like this COVID-19 is going to have a worse impact on you. And for those of you who aren't medical people, right, it's a pretty simple calculus, right? If I'm chronically stressed, my adrenal glands are constantly putting out adrenaline, which raises my blood pressure all the time. But those same adrenal glands constantly are putting out high levels of corticosteroids. And you need a little bit of corticosteroids to survive, right? And you need to be able to put out some adrenaline and corticosteroid if you're chased by a lion. But as soon as you get away from the lion, you can calm down and all that stuff goes back to normal. If you're chronically stressed because you grew up in an environment where you were chronically stressed, and then you're stuck in a situation where you don't know where your next paycheck is coming from, you don't know if your car is going to break down, you don't know if you're going to get evicted from your apartment, you don't speak the same language as the majority of people around you, you're getting this American dream myth sort of shoved down your throat all the time and told that you ought to just work harder and then you'd have all the things that you see on TV. Your steroid levels are high all the time and your adrenaline levels are high all the time and you can't shut them off. And that's really bad for your health. That's a great way to get diabetes and be obese. And lo and behold, it's a horrible thing if you get coronavirus because your outcomes are going to be worse because your body can't fight the virus as well as the next person. And so not only from a physiological perspective is this virus, having a major impact, it's having it from a socioeconomic perspective as well, because of the way that structures are set up, where people work, what resources they have to work from home or work on a computer or not. But what have I seen that's worked? I think we've all struggled. This whole country and really the world is struggling with COVID-19. But you do see international models, some that are better than others. But public health problems, they don't respond very well to individualistic ideals, libertarian political approaches. They need people who understand the way that that culture and social forces influence things. They need people that realize sometimes individual liberties may have to be sacrificed for the good of a community. Societies do that all the time, right? Again, some of you are students of different global societies and countries, and you see how certain things are put in place that elevate the good of the masses over the good of the individual. There's a whole range of doing this or not doing that. People around here, they mostly stop at stop signs, they mostly stop at stoplights, they don't just run them. And that's a form of them curtailing their their individual freedoms. We've in our region in Kansas and Missouri, we've had lots of people. I work with a lot of public health people who have been yelled at by community folks saying that having to wear a mask is a restriction of liberty, and that is just a slippery slope to a situation where the government of the United States is going to curtail everybody's rights to do all the things that they see as their inalienable rights. And I say to them, do you have to wear pants? Like, if you have to wear pants in public because we've decided that it's just too disruptive to have everyone walking around naked all the time, that's, I guess, a restriction on your freedom and liberty to be naked if you want to be. But it's something that nobody would question, right? But this whole mask thing has been really fascinating to watch. And it's shifted too. I'm sure some of you have noticed that as things have gotten worse and more people have known somebody that got COVID-19 and seen a relative get really sick, there's been a change of tune. I can tell you that I know 40 or 50 county health officers across Kansas that have seen their county commissioners change their tune in recent weeks, which is interesting to watch, but I don't think it gets us. I still think we have a major problem with polarization in our current environment. And partly it's probably largely, this is my theory, and I would love to hear some of your theories. I think it's largely because we do have a lot of smart people in our society now that they are interested in things like global health. They are interested in comparing what's going on in the United States to other parts of the globe. And it's almost undeniable that we have some ridiculous policies and ridiculous systems in place in this country. Certainly with healthcare, I think you could easily argue that, but I think you see some of the same things with regards to minimum wages, housing policy, um, gender equality. That there's a whole bunch of things where if you compare us to a lot of other parts of the world, we're just ridiculously backwards. And so people's fears of, yeah, it's Dr. Perales says guns, good one, very nice. It, it, I think there are people that have, people get used to their power and authority and wealth. And there's all sorts of structures and myths, right, that sustain their ability to keep that. And people don't like change. And then they get fearful and then they vote for crazy people, right, in elections. And then you really have this stark polarization that that in some ways doesn't get you any balance between a libertarian sort of selfish way of seeing the world and a blaming the victim sort of approach to a much more communal and egalitarian model. And there's probably happier mediums, and there's probably a way to create sustained change that there's a whole lot less exploitation going on. So I've been babbling for over a half an hour now, and I would love to hear some of your all thoughts about things I'm babbling about. And so maybe I could just start picking on people and get your thoughts in this regard, and hear what you're up to in terms of global health work, as well as trying to achieve equity. Jaime, you want to jump in and chat about your work? I don't know if everybody here knows you and all the good stuff you're doing.
I'm an assistant professor at the KU Alzheimer's Disease Center, and I mostly work with the Latino population. I have 2 projects right now. One is a KO1 that's trying to understand what dementia services are being provided to Latinos in primary care. And so the first few years are basically going to be interviews to primary care providers both in Kansas and actually also a little bit outside of Kansas as well. We want to know from different places. So if you guys know primary care providers, please refer them to me. And also the next one will be training these primary care providers to detect dementia as soon as possible in the Latino community and refer them to health navigation services to help them with a million types of problems that people with dementia have, especially Latinos that are mostly underserved, as most of you already know, because they have lower access, lower levels of support for caregivers with dementia, etc. And the other study that we have is we're developing the first text message intervention for Latino caregivers of people with dementia. And so these messages will basically be able to send them different tips of education, strategies to take care of themselves better and their loved ones with dementia. So those are the 2. I'm actually, obviously I'm not going to do this anytime soon, but within the next few years, I think if the text message interventions goes well, I would like to take this to Latin America And, because I think it could be very helpful. WhatsApp and texting is very popular in many of those countries. So it's something that could be easily done in an inexpensive way and reach a lot of, families with high fidelity and yeah, et cetera, et cetera. I've done other global health research before, first in Europe, because I'm from Spain. So we did it in Spain, Poland, and Finland. And then we did other stuff with mostly Mexico, but also, let's see, Russia, India, etc. In epidemiological research, basically. Big populations and looking at aging and risk factors for different aging problems.
That's great.
I did have a question for you. Do we have, or are we going to have a center for global health at some point? Is that some at KU? Is that something that's
probably a Kim Connolly question. I know there's been time. I mean, in some ways, her shop is a center. It's had a little bit less of I think a research focus over time, but I think that's been growing for sure, because I know she's working with more and more researchers, certainly a lot more than her predecessors did in that office. Kim, I don't know if you want to
Yeah,
chime in.
very generous of you, Dr. Greiner. Dr. Sarah Kessler has been involved with a kind of a movement to have a global health center. We had a couple of presentations to senior leadership. And after the presentations, it was decided to kind of put an actual global health center on hold, because Jaime, it's interesting. I learned a lot as we looked at this. And to Dr. Greiner's point, we would be like one arm of a center, OIP, kind of the support, mechanism like we currently do. But there's a lot that goes into a global health center, because it supports the clinical, the research, the education. So it takes a lot of people to actually make it happen. And there's some strict kind of definitions of what you need to be a global health center. You can't just say, oh, we're going to create a center. So we have to meet some very specific criteria. So Dr. Samari, because of the interest on behalf of faculty who are involved in global health work, whether it's like Dr. Greiner here locally with health inequities and disparities, or if it's someone like Dr. Kovac who's involved in education in Ghana and Peru, there's a lot of interest. So he appointed Dina Kinwantan to be kind of the head of global health. I wouldn't say all activity, but the faculty who are involved in global health, and trying to define some university goals and kind of working towards this. So I would say it's in our horizon, but we're not quite there, and there is a lot of talk around this, and certainly Jaime, we need to make sure you're added to the faculty list. It's not, how do I say this? The list is inclusive. We want anybody who's interested, who's involved in global health, to be part of this group. It's a very large group, and I think we haven't met at all this year due to COVID. I think our meeting had been scheduled in February. Dina Kinwantan had our last meeting in February, and we haven't had one since then. So, but I will make sure, if anybody has interest or wants to make sure they're on that list, if you're on this call, please send me an email, and I'll make sure that your name gets added to Dina Kinwantan's kind of listserv for the global health faculty.
I'm not her, obviously, but I know that Mariana would also be very interested. We're talking about collaborations in Mexico, for example, and we've worked in Mexico, Mariana and I, with
yeah, I'm pretty sure Mariana is on that list, because she would have been on my list that I shared. Yeah, but we'll definitely add you. Yeah.
Then she should have talked about me then.
That's great. That's good. That's really exciting. Yeah, good stuff from both of you. You know, and there's a question from Aiden in the chat. To set that up, I'll talk a little bit about how Dr. Prowlis and I mean, we're sort of academic types, right? So we pursue grants, but I think academic people are kind of committed to this idea that you're going to do educational stuff with your students or other learners. You're gonna do research stuff, and in many cases try to get grants, but you're also going to do service things. And historically in healthcare and medicine, that service would get chalked up to, oh, I take care of patients, I cover the ER, I cover the hospital. Or if you're like on the KU Lawrence campus and you're not a healthcare person, that service might be internal service to the institution, but you can also turn that service external, right? And so you could, as an academic, do all sorts of things to help populations or help entities or help groups, and that could be very much a global health enterprise, or it could be a local enterprise. Like I do a lot of stuff with nonprofit organizations, and they're probably not a whole lot different than NGOs that do lots of global health work. But for me, over time, and Aiden asked this question about COVID, but for me, over time, I think in an underserved or a marginalized community environment where you have a lot of health inequities, the most important thing to see change happen is and this again is probably influenced by my interest in culture, but is just to see people continuing to do work that brings a positive and optimistic approach to that setting. So if you don't have a critical mass of people trying to do project activity and trying to make things better, whatever way they might be trying to do it, I think it can be hard to get movement forward. Because what happens, I think, in most communities or environments, and this could be entire countries too, right, that have inequities, is you have a long history of withdrawal of resources. And even though there may continue to be a withdrawal of resources in environments where you all are working, by going in with the positive attitude and saying, we need to work on this, and we need to work on this, and we need to work on this, and just bulldozing your way forward, I think makes a difference, because other people see it, and it generates this sort of energy that's kind of infectious, and other people pick it up. And I feel like in Wyandotte County, where I've been working for over 20 years, I think we've had a little bit of that over 20 years. It hasn't been massive, but it's been some change. And we've tried to bring a similar approach to COVID. And I hope it's made a difference. I don't know. I mean, we've had some bad outcomes, but in some ways, maybe we've had a little bit less of a bad outcome than we would have if nobody would have done anything, and we would have just let things sit as they are. So one of the things, for example, that some of us tried to do out of the local public health department in Wyandotte County was number one, get a bunch of community input. So get members of different community segments that are historically facing inequities, and bring them into a position of providing guidance and input, and having a voice, having a true empowered voice to say, this ought to happen and this ought to happen, and think about this. And the other thing I think is really important is building teams, building diverse teams. And those teams can include regular community members, regular patients from the real world, people from small organizations that wouldn't necessarily get invited, to sit with the mayor or to sit with the governor and make decisions. Teams need to be big and diverse and pretty egalitarian, and so I think that's important too. And then I think bringing a sense of urgency to a problem like COVID, I feel like I've seen that work pretty well. When you get a team going, and that team is constantly pushing the idea to others that this is an urgent problem that needs to be addressed now, it just brings the kind of energy that makes things move forward. So some of us, I think, like like Jaime and myself, we want to do this kind of stuff with our research, I think. And it might not always look like it's even research, but without doing this kind of work that pushes the envelope on getting things done that are valuable to a population or community or patient group or set of families like he's working with, unless we do that, we won't have the relationships and the infrastructure to do the next project and the next project. And so if you all get into doing global health work, and some of you are already doing it, right? You may find that you're doing multiple things over time in this, in the same environment. And you really can build momentum by bringing, a kind of passion to the work, and an approach that's very open-minded. Again, this idea that you don't come in as the expert medical person or scientist, but you're looking for partners who may have this on the ground knowledge that you don't fully understand, but can guide and shape what you're doing in a dramatically different way. And there are different ways to talk about this, right? There are different frameworks. In the US, right, people talk about community-based participatory research in this way. But I think there are global health approaches that use a similar framework that can be applied and can make a difference. I see another question there. Somebody asked about sociologists. And I don't know if we have any sociologists on the campus here. We certainly do at other institutions in the region that collaborate here. But again, the diversity of fields is important, so I'm all for it. Somebody else was going to comment.
Oh, Dr. Greiner, I'm sorry. Oh, go ahead.
This is Kevin. I was one that posed a question. I asked because I'm a faculty in the Department of Sociology, and I teach a sociology of global health course at the Edwards campus, and I'd never heard of this group. So I was like, this sounds really fascinating. I'd like to, just be a fly on the wall in some of these conversations. So this whole talk, I've really enjoyed. It's been really fascinating.
Right.
I actually invited my students to come, and so they could. And I wish they had, because then they could have heard that I wasn't full of crap all semester long. Because it's like you've literally repeated everything that was in my course. I'm like, hey, you know what? I'm not crazy.
That's great. Well, Kevin, we have to get you on Kimberly's group, and we'll have to meet up. I know Dave Cook very well, who was the head out there at Edwards, and love to talk more.
Professor Kevin, we're so glad you joined us. And I don't know how you heard about tonight, but we definitely want to add you to our listserv of events. That they come out from Alexa Smith, and she's running the Zoom, so she can put her email in the chat for us. Dr. Greiner, I had a couple of comments, if you don't mind, at this time. Just, you said, there's so many things you said that I just loved, and it's hard to maybe summarize everything. First of all, I had no idea that you studied anthropology. I didn't know a lot about you. And so it's so fascinating to just hear your story. And I think it could be very motivating to a lot of people, because you didn't just know from the time you were 5 years old that you wanted to be a doctor. So I love that complexity of your interests. There's a lot of diversity there. A couple of things that you said, for us, COVID-19 has really given us an opportunity to take the emphasis off of international travel when looking at global health. And we talk about this, and we try to talk about this all the time, especially with learners, that global health isn't always about getting on a plane and going somewhere. It's really about what you have been talking about, and it's these teams of collaboration and really looking at health disparities and health inequities, and a lot of the ways we live our lives that create these situations, and where some are doing have more than others, and the system is set up that way to take advantage. And specifically, obviously, we're looking at it from a healthcare perspective. So we really appreciate that message that, people can really engage, even though we're not traveling right now, we're not getting on airplanes and going internationally. There's so many ways to engage with global health here in Kansas City, engage with health inequities, health disparities, understanding different populations, understanding different health systems. We do it virtually, we can do it in teams. And it reminds me, Dr. Mani, I think some of you might have heard of this name. He's a professor emeritus. He was a plastic surgeon who began his career in India. And he was recruited by Dr. Robinson and came to KU for residency. The idea was originally he would go back to India after his residency, but he stayed. And he did a lot during his career, helped set up the Burn Center, and went around the world helping set up burn protocols and such. His philosophy has always been to our students and residents and faculty who want to go out into the world relative to global health. His philosophy and message has always been, why do you want to travel when you can do this in your own backyard? You know, what is really the motivation? And trying to get people to really look at some of the philosophies and attitudes of coloniality and power differential and superiority, and trying to get people to kind of change their thinking to collaboration and mutualism, and trying to see if we can solve the problems or help with the problems in Wyandotte County, then how could that also then maybe translate to another healthcare system, but also vice versa. What about community health workers? You know, I've heard you talk about that, Dr. Greiner, and that's one of the things that many other communities around the world do very well. They utilize community health workers. And even Dr. Kessler, with her research in Kenya, I think you're aware, you know, she relies heavily on the community health workers and, like you said, former patients, and within her to keep her research alive and to make it work. And so we have great examples of systems around the world that, and especially with the community health workers, that those are examples we can learn from, utilize within our own communities here in the state of Kansas.
Yep. Oh, great examples. Yes, you need to get Dr. Mani on one of these sessions. That'd be fun.
We actually have him scheduled, I believe it's for April 15th, maybe.
Great.
Yeah.
Yep. Yeah, and I mean, when you hear him talk about what he used to do around the state of Kansas for rural communities here, and what he did with his global health work around burn care, he was doing this sort of thing I'm talking about, of like, when somebody said, can you come help us, he would just show up and help them, and it was like, let's do a project to get you going to take better care of people with severe burns and save lives. I remember as a student, like 30 years ago, when he was still practicing, and you'd be up there and he'd be going, no, these people don't need a bunch of antibiotics shoved in them. Yes, they're going to get infections, but what we actually need to be doing is this, 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 and this. And he was spreading that all over the place. And really it was part of a revolution that made a huge difference. And I think he was a great energy for that. He's got that personality that just makes it happen. We're getting close to time. Any final comments, questions, thoughts?
Hello, Dr. Greiner.
Hey, Karam, how are you?
Doing well. I really enjoyed your presentation. I have a question kind of looking long-term for students, young professionals, whatever. As we get more further in our career and kind of move out to different communities, whether it be in Kansas or other places in America, or et cetera, what's the best way to like get involved? Who's the person to reach out to? Is it the local health department? Is it whatever institution is in the area, or does it kind of depend on by region?
Yeah, I mean, I think that if I were going to summarize it, it would get back to a couple of things I talked about before. You want to work in teams, right? So you want a diverse set of people that you're working with on whatever it is you're working on. And sometimes the easiest thing to do is find the people that are already kind of a team especially if they have that positive, optimistic attitude of we can do this, we need to take action. So if you can find that network, it may not be public health at all. It may not be the nonprofits. It might be other governmental entities. It might be the business sector. I think you never know, but you've got a network to find that, right? So your job, and the nice thing in healthcare, a lot of times if you bring your healthcare piece to this, people want a healthcare person involved in things. And so you bring that and you say, I want to get involved, and you become part of that network, and maybe you build it out to be more diverse and more robust. And then I always say, I have this other talk, I didn't use this terminology before, but like I always just say, just do stuff, just keep doing stuff, right? So it's this positive attitude of like, we can do things that make a difference and find stuff to do. So if you find these teams and these networks, your objective is to just keep doing things, because it's that infectious sort of culture change of moving forward, learning from your mistakes. They're not always going to work, but not everything works, but you'll be energized by that, I think. I mean, you and I have talked enough to know, I know that's where you're going to go. You just have to figure out where you are and start doing it.
Thank you. I appreciate that.
You betcha. Okay, we're out of time. It's 5 o'clock.
It's dinner time. Hey, Dr. Greiner, I just really want to thank you so much. I really appreciate this more casual approach. We said we would like to have, kind of conversational rather than presentations from the individuals participating in the foundations of global health. And I think there's something really endearing about it. And we all feel like, and I don't know if Zoom also contributes to this, but it just feels like a lot more intimate, and like we really got the opportunity to get to know you a little better. So I appreciate that.
You bet. My pleasure. Hope everybody enjoyed, and hope you all have a great rest of the week and keep doing good things.
Thanks, everybody. Have a great night.
Thank you.
Thanks. Bye-bye.